Now we're going to record your plans. Okay. The folks are still entering, so we'll give it a couple minutes. Annie, long time no see.
I know. Good morning. Good
Yeah,
morning.
wait, Annie and Annie. Sorry, hopefully I get you both. There we go. Yes, Danny, also.
Hey, good morning.
Good morning, Sherry. Folks are still entering, so we'll give it another minute or two. Danny, I'm not sure I realized you were doing both adults and children's. Children.
Yes. I have a QMAS for QMAS has everything.
Huh? I can't hear you. I'm sorry. I'm very frustrated. I'm fine. What?
Anyway, Michael, the sun is shining behind you. It's beautiful. Sun.
Yeah, I'm gonna be wherever that's at right
Is that your own picture?
now. No, I downloaded it.
Oh, I was gonna say, I'm impressed with your photography skills. We still have folks entering, so we'll give it another minute, I guess. We'll go 8:05. Come higher, come hell or high water is at the we saw people entering. Stragglers on a Friday morning. All right, we're at 8:05, so I think we're going to go ahead and get started. We still have folks coming in, but we'll keep letting those folks in. So good morning, everybody. Diana Boyer, I'm the Director of Policy for Child Welfare and Older Adult Services at CWDA. And I want to just briefly and quickly introduce our team. So I, first of all, am really happy and proud to say that we have a new Director of Aging and Older Adult Services, Renita Polk. Renita, can you say hello real quick?
Hi, everyone. I'm looking forward to hopefully at some point meeting and talking with all of you, but glad to be here.
Renita started with us right as we were getting into state budget and May revised time. So she's been able to jump right in. So thank you, Renita. We also have Baljeet Hundal, who is our consultant on Cal-AIM and a former deputy with with Mariposa County. Baljeet, you want to say a quick hello?
Morning, everyone. Happy Friday.
And Andrea Sobrado, want to do a quick intro for her, Deputy Director, hopefully getting that right, with CFPIC. And we've been doing a lot of collaborative work. Really, CFPIC is helping us lead in the space of CalAIM to support county implementation of CalAIM work. So Andrea, you want to say a quick hello?
Yeah, good morning. I'm so sorry it's 8 o'clock in the morning. This is really early. Looking forward to a three-day weekend though. Good morning.
Yeah, so thank you for the scheduling issues. State budget kind of has thrown us into a loop here. But so the reason that you are here is for us to give you a walkthrough of the what we're calling an IHSS kind of kitchen sink MOU. So CWDA had been working on the child welfare side with some consultants, different consultants, including Belgique, on creating a template agreement for all county child welfare agencies to use. And then we saw fairly quickly that there could be a benefit to you all in having an IHSS template MOU. And so Belgique and I kind of took a lesson from the child welfare side. Didn't quite get as ambitious from the child welfare side for the IHSS one. But we mocked it up. You have it. We'll give you a walkthrough of it. We're going to give you a bit of sort of context setting before that. And we shared it with a group of counties, IHSS. So for those of you that were part of this small working group that informed us on this MOU, thank you very much. We also had a conversation with Partnership Health Plan over the MOU. They gave us some really great feedback, at least initially. We had hoped to get some additional feedback from them, which they did not send. They may have their own reasons, so we can't say that this is a template that they have signed off on. So I just want to be very clear that no mental managed care plans have signed off on this MOU. This is just something that we've created and developed, but we did get at least input from one of the managed care plans. We also shared it with the Department of Healthcare Services and their staff that established these template agreements. They gave us also helpful feedback and did not push back on anything that we put in there. So that's very good news. As the department has said, these templates, you can add to it. There are just some things that they do not want to have taken out. There are sort of some baseline requirements there. And so Belgique and I will, walk through that with you and make sure that you understand kind of what's in there and why, what things may or may not be changed in it. And then we hope to have, certainly some time for a little bit of, Q&A and discussion and kind of temperature checking with you all in terms of how it's going locally. So I think that kind of and also we'll talk about next steps and meetings with plans after we go through the template agreement. So I think that covers everything to start with. Before I turn it over to Belgique to start with our PowerPoint presentation, are there any initial questions or things you're hoping that we'll cover at some point in this meeting? All good? Okay. Oh, I didn't look at the chat.
Come on.
All right. Okay, I think we're good to go, Belgique.
Great, thank you. Just 1 second while I pull up my PowerPoint. We did share it in the chat if you need it. All right, so just a reminder again that CalAIM, now called Medi-Cal Transformation, though I think everyone still calls it CalAIM, California Advancing Innovative Medi-Cal. So this is a multi-year effort. It really is looking to help every single Medi-Cal member be provided with more standardized access to care, streamlined, more enhanced services and benefits to them as well, and really identifying those members that typically are seen as high risk and high vulnerable populations that we serve. And all of this work is being accomplished through the managed care plans. And so it is very crucial that we understand that populations that we serve do need to be enrolled in a managed care plan to fully access the benefits and services under Medi-Cal. And the state has made has made a lot of efforts to move members over to the managed care plans across the state, and they continue to roll that out. And so one of the items that the state really looked at through this process is, some of these partners that the managed care plans need to work with and collaborate with and coordinate with to better provide services to the high-risk, high-vulnerable populations. And they're really looking to do a lot of this work through the MOUs. And so we do have several MOUs that do impact social service departments, health and human service agencies across the state. And so the MOUs are really around, about relationship building. If we don't typically work or coordinate with our managed care plans, this is our opportunity now to really lean into that and really start building relationships with our managed care plans. And so the MOU can be seen as a tool to start that process, to start having conversations around the services and benefits that your agency provides to your populations and how can they align better with the managed care plans and what they offer through the Medi-Cal program as well. And if you've seen these slides before, I apologize. I did steal them from our slide deck that is part of our CalAIM 101 training that we have been providing last month and this month to county staff, but really trying to help counties understand that managed care plans, though they have the responsibility of executing these MOUs, and are reporting back to the state on those efforts, they need us to also join them in this and for us to really look at how do we partner with them and starting those conversations. And so probably at the end of the presentation, at the end of the walkthrough of the MOU, we will ask some questions around how those efforts and engagements are going on in your counties and how is it going? Who's initiating the conversations? Where are they? And where are you in the process? But so one of the things that we are really trying to help counties look at is that our managed care plans across the state may not really understand a lot of the programs that the departments offer and provide to the community, and their understanding of the IHSS program in particular may be very limited. And so it's our opportunity to really help them understand the program, how it's organized in your county, how do you provide the service, the workload, the staffing, all of that. That this is our opportunity to kind of help them understand the programs better. They have I would say they have very limited understanding at this point of the program. And so it's an opportunity for us to really help them understand the IHSS program much better. And there is a piece in the MOU that talks about training, and we'll talk about that when we get there. So these, the goals of the MOUs, these are from the state. As it says on the slide, it's really about establishing minimum requirements around key contract provisions of the MOUs. And we're going to go over each of those. One of the things that DHCS did share with us is that there is language that they put in the MOU that is for the managed care plan per their state contractual agreements. And so it was very important that we did not change any language that was a mandate for the managed care plans. The MOU really helps and seeks to clarify roles and responsibilities for the county and the managed care plans around coordination and delivery of services to that end user, the member. it's looking to formalize some of these processes, and there are places where it talks about policies and procedures, and so we'll highlight some of that as we go through the walkthrough. A critical piece in the MOU is the data sharing and exchange. And I know through our conversations with some of the counties, there is definitely a lot of concern around, what kind of information does the managed care plan want? What do we want back from them, and how is this going to play out? And so we'll talk further about a lot of that and how a county can approach that with their managed care plan. And then, the oversight and accountability of the MOU. There is language in the MOU around the managed care plan's responsibility, and as well as the county. Again, I would say a lot of this is placed on the managed care plan because they will be reporting back to DHCS, not only on the execution of the MOU, but just the continued oversight and accountability and compliance of the MOU as well, that will be a responsibility of the managed care plan. So these, the next couple of slides, just going to go over some of the areas of the MOU, and you'll see if you are also involved on the child welfare side, that they do have similar areas, and then just differences in how each area is defined based on the population. But basically, each MOU does look at the services covered by the MOU, so it describes that. There are definitions that are identified in the MOU. There's party obligations, and that means what is obligated for the managed care plan, what is obligated for the county, the training and education piece. How is each entity going to help the other entity understand what they offer and the services and the programs that they oversee? And so there's quite a bit there in the training and education. The referrals, how are referrals going to be made from one entity to the other? And so there is language around that. The care coordination, how when members are identified as being in the IHSS program as well as a managed care plan member, how is that care coordination going to occur? And this was one area that the counties were really concerned about. And so taking that feedback, we did add language to, I think, hopefully make it more reasonable around what care coordination would look like in the IHSS program. Data sharing and confidentiality, this definitely was another area that counties were concerned about, sharing information without member consent. And so we have added language that I think would help in that area as well. There is also in the MOU language around a quarterly meeting that needs to happen. That is the minimum requirement. It can definitely happen more than that if a county and a managed care plan chooses to do that, but these are the minimum requirements. And then there is a quality improvement requirement in the MOU as well. Again, we did add language that I think hopefully will soften the requirements around that a little bit for the county. And so that, the quarterly meetings can be definitely utilized as a way to get through some of those quality improvements if identified by the county and managed care plan. And then dispute resolution, this is in every single MOU, that when a county and a managed care plan can't come to resolution on something, that they will involve DHCS and or CDSS. And we couldn't really think of reasons why there would be disputes between the two entities. We have asked for examples of this where we would need to involve DHCS or CDSS, but really I think it's around maybe not being able to execute the MOU more than anything else. So those are the major components of the MOU. And then just a couple of things that we wanted to lift up, because there were concerns around, does this allow the managed care plans then to authorize hours and play a bigger role when it comes to IHSS? And that is not the intent of the MOU. The county IHSS program still has that role and responsibility. And so this MOU is not looking to transfer or allow the managed care plan to take over that role as well. So that we wanted to make that clear. Again, it's really intended to support the coordination between the county IHSS program and the managed care plan on when you have a Medi-Cal member and you have an IHSS recipient and they're common to both programs or both entities, how do you work together to best meet the needs of that recipient? And then again, one of the issues that did come up, and it is in the state's FAQs around if you had previous MOUs with your managed care plans. We do understand that some counties do have existing MOUs, that you do have to move forward with this MOU still. And so it is important that we made that clear that your prior MOUs are not a replacement for this MOU, that the managed care plan does have to execute this MOU because it puts additional responsibilities on the managed care plans that may not have been captured in previous MOUs. So I know, I want to say it was like over maybe a month or so ago, Diana and CWDA did put out guiding questions to help you in your engagement with the managed care plans on how do you want to start the conversations. Again, how do you help them understand your program and how it's structured and how you provide those services in your county. Again, the MOU is a vehicle for those conversations, but we also added additional questions through that guidance on how to approach the conversations around each of these areas of the MOU. We can definitely share that again in the chat if you did not get a copy. So in the MOU, you will see that there are 4 positions, and it's on the first page on the definitions. And these are positions that the state is asking for each entity to have. And so you have 2 on the managed care plan side, and you have 2 on the county side. Now, these can be combined. It doesn't necessarily have to be 2 different people. And so these are the folks that are these are the positions that are not only going to help with coordination, but are also going to make sure that each entity is in compliance with the MOU. And we'll go into that more as we walk through the MOU. So one of the things that was really lifted up through the conversations with counties, and I think Diana and I talked about this quite a bit as well, is just some of the administrative load that comes with the MOU. And so that's what this slide really tries to capture, is that, when you decide to execute the MOU, it does come with some of this administrative activities as well. And so that includes the data sharing expectations and requirements. We have the quality improvement, and then we have the trainings and potentially any policies and procedures that you identify in the MOU, then those have to be executed, right? Have to be written and finalized. And so these are some of the administrative activities as well that are part of the MOU. So I'm going to stop sharing. See if anyone has a question.
No question here, but as we're getting ready for the next part, as we're going through the template, you'll also see where, while this is an IHSS focused MOU, we are wanting to introduce opportunities for some support and I guess nexus to your APS programs as well, especially in light of potential budget cuts in APS, the ending of Home Safe potentially. Again, these are all proposed in the state budget and not made into final decisions yet, but there is that added pressure, certainly, and the client population of our older adults is only growing. And so, you know, the overall goal and desire and expectations of these MOUs and why we have them is because it's a message from the state to local agencies and to health plans that we are all serving many of the same populations. And the desire is to just create that better alignment, to leverage resources, to coordinate in those resources, to eliminate duplication, and to work together in a more streamlined fashion. Because, you know, of course, the clients that we serve are served by multiple different systems, which can be confusing for them as well. And so the desire is really to work together across systems. And this is just the starting point. This is going to be a long road and evolution. CalAIM is a 5-year demonstration project. And if some of you have been on the 101 or 201 trainings that CFPIC has hosted, that question has come up. And we do anticipate like this is not going to just end in 5 years, that this is a test to demonstrate its effectiveness. And the goal and desire would be to continue a lot of this work beyond the 5 years.
All right, so I did put in the chat the guidance questions in your conversations with the managed care plans. And then if there's anything else that you need, let us know and we'll add that to the chat as well. So I'm going to pull up the MOU now. Okay. So we'll start with page 1. So page 1, first thing that we added here under the 3rd paragraph. So there was concerns that were highlighted by the counties that spoke with us around what does it mean in the sentence, whereas the parties desire to ensure that members receive IHSS in a timely manner. There were concerns around, well, what does timely manner mean to DHCS? What does it mean to the managed care plans? And so we added language that says pursuant to existing state requirements. So what we are already required to do, that is what we mean by timely manner. So we added that language there. Then the next, oh yeah.
Quick pause, sorry, there's a request if you could increase the size a little bit.
Yeah. Is that better?
I think it looks great.
Right. All right, and then the next area, oh, Elsie?
Maybe that was an accidental hand.
Okay. Then the next area that we added more content was under definitions. And so the first area that we added more language was the MCP reasonable person. 1A, we added more language that we pulled from the FAQs to better define what this particular position was going to do. And so you'll see all the bolded, underlined language there to better understand what this position was going to do. And then under 1B, we added language around the LTSS liaison position. This is a position that would work with the IHSS managed care plan staff as well as the IHSS program. And so we added that position here as well to better understand that it's more than just the two that were identified in the MOU that the county could potentially be working with, that you would also potentially be working with this position as well. In our conversation with Partnership Health, we better understood the LTSS position. And one of the things that I remember from that conversation, because we thought that they would combine the positions, is that might be a workload issue for the managed care plan, because that is that might be a high caseload for that LTSS position. And so it may be additional person that you're working with. And so we added it to the definition so that you knew that there was that position as well.
Yes, and so a couple other things. So the language that we pulled, again, this is when we also talk with DHCS. They actually pointed us to how we might want to structure this in the MOU. So that was very helpful technical assistance we got directly from the department. And then, of course, as we know that the LTSS liaison is not potentially only going to be serving IHSS consumers, right? There are a range of individuals that may need to be receiving this support and service outside of our programs, including APS as well, clients. So a really helpful addition, I think, for our population to receive this support from managed care plans.
Right. And then under 1C, so the IHSS responsible person, this is a county position that the MOU is calling out. And so one of the concerns that we had heard from counties was obviously, who is going to take on this responsibility at the county, recognizing the workload impacts currently, the high caseloads and everything. And so we added language not only to the IHSS responsible person at the county level, but the IHSS liaison at the county level, that these positions would accomplish the activities of this MOU only to the extent that the county has the available staff resources to do so. And so we did add that language to both C and D. And then under D, you see that we struck out facilitate, which kind of makes it sound like it's the county's responsibility to do certain things. And so we changed that language to collaborate and participate with the managed care plan. And then the last definition that we added to the definition section is the multidisciplinary team. We added this because you'll see later we have added language around asking the managed care plans to be part of MDTs when they are called for IHSS recipients. And we do recognize that these typically are coordinated and facilitated by the APS side, maybe more so than the IHSS side. And so wanting the managed care plan to be a part of that process as well. So the next area that we add or edit language is under the managed care plan obligations, which is item 4. There were questions, and you'll see the comment there around authorizing medically necessary covered services. And so we added a comment and then a reference to where you can find more information about that. The added language we added under 4A is and this was something that we really were trying to get more on the child welfare side as well, and I can say this as a former county employee working on CalAIM in Mariposa County. I wanted more say in who the managed care plan was authorizing as an ECM and CS provider, and that we have our network of providers that we work with. We know, the ones that we want to lift up. And when we did present this to Partnership Health, this is the language that they felt would best meet that need. And so what we added here was that the managed care plan shall share its enhanced care management and community supports network with the county's network for aging and older adult services to promote alignment. Again, it doesn't really give us the authority to push for particular providers to come on as an ECM, but it does ask for the managed care plan to coordinate and really talk and communicate with your county about who is coming on as a provider. And also, we can share who we want to come on as providers as well, right? The providers that you typically work with who would be a good choice as an ECM or community supports. And then we added language here around the LTS position again, as an obligation under the managed care plan, that they would also be a part of this work on the IHSS side as well. And then this is where we ask for the managed care plan to be part of the MDT, and then we added softening language for them as well, as best as they are able to, recognizing their workload and impacts as well, and would they be able to attend every single MDT. But putting it in here at least allows the, lets them know that this is something that counties would want for them to be there. Again, they have an array of services that they provide, and they would be a great partner to be at an MDT to offer services that maybe a county is unable to provide themselves. For example, transportation services. And so, in IHSS, when I used to oversee this program in Mariposa County, transportation was something that probably wasn't something that we would do as a county entity in IHSS, but the managed care plan does have this requirement and obligation. And so them being at an MDT, if transportation is the barrier, they would be able to offer that. And then one of the things that we learned from Partnership Health, and tried to really be mindful here, is that anything that you put in the MOU is open for audit and compliance for the managed care plan by the state. And so anytime we added language that said, you're going to do this and it will be captured in a policy and procedure for them, that would initiate a potential audit. And so they were more comfortable with language that said training. And so we did add that here. And you'll see the comment on the side to explain that further. We did strike out some things that we didn't feel was necessary in the MOU, and these were suggested items anyway, and you'll see the strikeouts there. And anywhere that we saw a must, we did try and soften it to shall or may as a way to soften some of this as well on the county. So we get to training and education. So some of the counties that are present are aware of this, that we have been working with CDSS. They really stepped up on the IHSS side to help with the training piece of the MOU. That was definitely a big concern of the counties. was the training of the managed care plans around the IHSS program. And so CDSS has agreed to provide a training for the managed care plans. We have had one meeting with CDSS, and some of your county peers were part of that meeting. They are looking to do a training similar to what they called their IHSS refresh module training that they currently provide. They took all the great feedback that was provided by the counties on what they would want to see in that training for the managed care plans. And they were going to take it back, work on it, and then present us with a draft of the training before they finalize it. And so hopefully we'll hear back from them soon on where they are with that progress. And so you'll see in the training and education at the bottom here under D, we did add language that says this provision shall be implemented contingent upon the availability of training provided or arranged by the State Department of Social Services. The other thing that we added here is under B, that we asked the managed care plans to seek input from the county in any informational or educational material about the IHSS program that was to be provided to members. And then for them, it was important that it was culturally and linguistically appropriate, because that is part of their state requirements as well. The other thing here, again, at the end, right after D, is just softening some of this language from county must to county may provide its county social workers and other staff with training and educational materials on MCP's covered services, including non-emergency medical transportation and non-medical transportation to support IHSS consumers and their care providers, not necessarily staff, but more for the recipient and their providers. Now, I think it's important that county staff do know what the managed care plans offer in their slew of services beyond just what is being provided through CalAIM. And so this is something that, you know, we are really trying to help counties understand, and you'll see more trainings around this through CFPIC.
I just wanted to just really quickly kind of respond to some comments in the chat. So you'll see here what Baljeet was just covering was the parties may agree to additional requirements such as, and anything in that is completely permissive. So below that, you see the county may, we changed it to may from must provide. In a previous section, there was a same in that same, I think it was training also, maybe Belgium, but it said that the parties may agree to additional requirements. And then we said there, the county shall review training and information materials. So we kind of like suggested an obligation on you. You don't have to add that. It was our thinking, you know, that you would want to see what managed care plans are putting out there for consumers and have some say in it. But you know, if that's something that's beyond your capacity, staffing wise, then you don't have to do that. So just to underscore that, where there's others shalls in the document, in the baseline agreement, when of the agreement that DHCS sent out as the template, we are by and large restricted from changing shalls to mays. There was one place here that we did, and it related to when, and I don't think we've gotten to it yet, but it's when there is a healthcare plan feels like an existing client needs more services. That really, you know, that request for additional services really does need to come from the consumer and not from the plan. So otherwise, like everything that's in that core standard template that DHCS sent out kind of has to stay as, if it says a shall, it kind of has to stay as a shall.
Yeah, they were quite clear on that. All right, referrals. So like Diana said, you know, changing some of the language to soften it. So we changed must to shall here. And then we also added language under 7A at the bottom. So for members who may be eligible to receive IHSS, who desire IHSS but are not currently receiving IHSS, MCP must submit member referrals to IHSS using a patient-centered shared decision-making process that shall be developed jointly by the managed care plan and the county and described through subsequent trainings and toolkits. So this is language that we added so that it was a process for both entities to jointly coordinate together and decisions to be made together.
And I just wanted to jump in here again too. So again, I mean, this is really a critical area for you all, right? Like for those that referrals that are coming from plans, this is where the worry is that you will get overwhelmed, right? And so we want to make sure that you have an opportunity to help guide when those referrals come to you. On the changes in this document from the must to the shall, I don't know that it softens it as much as it just, we try to make it kind of consistent throughout in terms of the terminology there. It is intended that you would be doing this. So sorry, I just wanted to kind of balance that a little bit. It's a bit of a, it's still kind of, it's perceived as a requirement still.
Yeah. So then under 7C, we again added a little bit more language there, asking the MCP to make the county aware of any change in condition for IHSS. And then we did strike out the language around to conduct an eligibility redetermination. This was something that was highlighted by counties, and so we did change that language. Under 7D, we've added language here, again, around MCP shall provide the IHSS liaison information regarding its process for screening and accepting referrals, and shall provide a written list of ECM and any community support services and instructions for referrals to the IHSS liaison that can be shared with county staff. And then under E, if we added some additional language there, if county is notified by an MCP representative that an existing IHSS participant has a change of condition, county may follow up to determine if a reassessment of our IHSS is needed. You already have your determinations and processes, how you handle this. And so that decision on what you're going to do is still a county decision. And then we did strike out the closed loop referral language here because that still needs to be, guidance on that still needs to be provided by the state. And so we did take it out of the MOU currently. All right, so the next big piece is number 8, care coordination and collaboration. This was definitely an area that the counties had quite a number of concerns around. What would this exactly look like with the very high caseloads currently? You know, what we heard quite loud and clear and just recently as well with one of your peers is the caseloads are so high that the social workers are primarily in the field doing the assessments and reassessments. And so what type of care coordination would occur here that may impact their ability to do the assessments and reassessments? So we added some language to kind of help understand that better. So under 8A, The MCP responsible person shall oversee the care coordination activities and communications and shall identify any care coordination issues to be communicated to the county IHSS responsible person. And so this really places that responsibility on the managed care plan more, I would say, to initiate this with the county. And then we struck out the individual under the parties must discuss and address individual care coordination issues or barriers to care coordination efforts at least quarterly. We couple of issues there. One is why wait quarterly to talk about individual issues? That seems like a long time to wait. And then these quarterly meetings that are part of the MOU, what we heard from some of the counties that were CCI counties is that when you start talking about individual cases in these quarterly meetings, the meetings turn into 5-6 hour meetings. And so we didn't want to turn those quarterly meetings into that for you guys. Let's see, under 8.3, we added just some minor language right here. MCP must assess members transferring from one care setting or level of care to another. And we added language that says as appropriate. And then further down, we added some additional language here. MCP shall provide informing materials to the county to accomplish this objective for use again around the covered services. So alignment with what we added earlier, just continuing that language here as well. Parties shall develop policies and procedures for coordinating any ECM or CS. And then also shall develop policies and procedures for participation in multidisciplinary team meetings, including participation of ECM case managers, LTS liaison, and others as deemed necessary. Again, this is additional language. If you know, you decide locally that this is not something that you want to pursue, you can definitely take this out. I think the managed care plans would be happy with anything that says a policy and procedure, and we decide to take it out. Quarterly meetings. So this was another area that counties were a little bit concerned about in regards to what these meetings would be and entail, the length. And so we did add some language here around the state wants them to occur quarterly as a minimum. And then just the length and frequency would be mutually agreed upon by both parties. Again, former CCI counties were concerned that these meetings in their experience had turned into very long day meetings, and they wanted to avoid that for this MOU. So we added a language to the MOU to capture that. And then under 9D, it says MCP must report to DHCS updates from quarterly meetings in a manner and at a frequency specified by DHCS. We added and shall provide copies of these updates to the county IHSS liaison so that you're aware of what's being reported back. And we get into quality improvement. This was another area that counties did raise as, well, what are these QI activities? What is potentially going to impact the counties? And so we added some language here. What exactly the QI activities are going to be are unique to each county and the managed care plan. And so there's nothing in the MOU that says what these are. It's something that has to be developed and decided at the local level. So we added some language that talks about these quality improvement activities shall be articulated in policies and procedures developed by the managed care plan with input from the IHSS responsible person and shall be consistent with DHCS FAQs, which state, and so we just added the language here about that. Again, what those actual QI activities are going to be will be decided at the local level between your department and the managed care plan.
And I'll just say right here, you know, we're having very recent discussions around the challenges in county IHSS QI activities. And so our goal here is to not put any additional workload onto counties. To really have this drive through the managed care plans, and any data that's needed, of course, as stated here, would be coming from CMIPs. We will probably want to have some further conversation with DSS, because any data from CMIPs ideally would be something that the state provides managed care plans, and not that you all have to do that. So this is going to be, I think, an evolving conversation that we'll want to pull in DSS and also fold into the conversations we had already planned to have with DSS on QI activities.
Yeah. And besides aid codes, we are not really still clear what else is being provided to the managed care plans at this point. And so as we get into the data sharing and confidentiality and data exchange, that was something that we wanted more information on from DHCS. And if I remember correctly, they were still looking into it the last time that we asked. But all we know at this point is that it's aid codes. So the data sharing and confidentiality, it says, the language says the parties must implement policies and procedures to ensure that the minimum necessary member information and data for accomplishing the goals of the MOU are exchanged timely and maintained securely and confidentially and in compliance with the requirements set forth below. We did not add or delete any language here, strike out anything here. This really has to be decided at the local level for each county based on feedback from your county council. You know, there is a FAQ that goes into this more, and we've referenced it here in the comments. What we have heard from several counties is probably if there is not a release, they're not going to give anything beyond a member signing a release and what they say that can be shared. And the data exchange, kind of a similar thing here. Again, a county really needs to decide at the local level, per guidance from your county council, what is the data that you want to share. As counties were talking about the workload, I just got this visual in my head of someone creating these spreadsheets and everything, and then sending them to the managed care plans. That's a huge workload issue, because currently we don't believe that there's a CMIPS information being shared. And so how would this then be shared with a managed care plan? So again, if you decide to share information, just looking at how would you share it, what format, what way would that happen, and just some of the workload impacts of that. We did strike out some information here again, but we did add at the end, if member authorization is required, the parties must agree to a standard consent form to obtain member authorization to share and use information for the purpose of treatment, payment, and care coordination protected. So, you know, you may have a universal release form already, making sure that the managed care plan is okay with that form as well, if you decide to utilize that as a way to share information. They did have the disaster and emergency preparedness as part of the MOU. We did strike it out, but you can definitely keep it. As someone who worked in a county where we had yearly wildfires. I will say that the last wildfire that I worked on in Mariposa County, the Oak Fire, we did find that our managed care plans really stepped up to the plate with us during that disaster. They were present. They were on site for us. And so if you don't want to include it in your MOU, I would definitely say have a conversation around what would the managed care plan do during a disaster for your county and its residents, and especially your most vulnerable populations, which includes the IHSS population. Dispute resolution, again, like I mentioned earlier, this was kind of an area that we didn't really know what disputes the county and the managed care plan may need to get the state involved in, but the language is here. It's something that needs to stay. We did change it. We did add language per what we heard from Partnership Health of 30 days for dispute. If it can't be resolved, to then take it up with the state, but nothing else really added there. And then I think this is the major last thing in the MOU was there was a concern that was raised around if a managed care plan or one of its subcontracted providers, such as an ECM provider or a community supports provider, makes a referral for IHSS services for a member, does that mean that that member then goes to the top of the list? And so 13 in the MOU, I think, and DHCS did say that that's true, really clarifies that nobody gets special treatment out of this MOU or gets pushed up to the list unless it's based on requirements that are already part of the IHSS program for expedited assessments when folks are in the hospital. Beyond that, there is nothing else in this MOU that is looking to expedite managed care plan members into the IHSS program. And then I think the last major thing on this was the exhibit. There was an exhibit that listed out what you may agree to additional data elements. And we struck this all out because, again, at the local level, you need to decide if you are going to share information beyond getting a member's consent, that this would be language that you would add yourself, but we struck it out at this time. So I think that's the entire MOU. Any questions? I'm going to turn it back to Diana to continue.
Thank you. So I know we went through a lot of information. You have the draft MOU. We kept the comments there so that you can kind of see for context why we added certain things in certain places. When you talk to your managed care plans about these MOUs, we would recommend I would think we'd want to recommend not including the comments. And Baljeet, now that I think about it, we might want to send a clean copy that's not marked up with our comments, so that they could, send it to their managed care plans. One thing, and I see Faith, I will get to you in a second. One thing that DHCS has been emphasizing is that this is a starting point. No county should receive an MOU from a managed care plan that says, here, sign this, like with a red line copy. They fully expect discussions, conversations, relationship building around MOUs. So look at this document more as that. Start with the bigger picture, like that is our recommendation. Baljeet did put the guiding questions in the chat. Start with the questions like, how much do you know about IHSS? How much do you know about the consumers that we serve and their needs and the work that we do? And what are your goals? What kind of community supports do you have? What kind of, who are your ECM providers? How do we bridge to serve our clients? We know your social workers are overwhelmed. Absolutely. And so how can this be an additive for your staff so that when they're going into the homes, and they see a need, they could say, okay, you know what, I think, this might be an easy referral, and this will help take care of it for you. We know many of the counties have public health nurses. And so this is probably an area where you would want to also include them in their thoughts around how managed care plans can be helpful to the work that they're doing to support your programs. So let's, okay. Faith, you had your hand up. Where did you go?
Thank you. Okay, so the question that I have, you answered it. Good morning, everybody. Happy Friday. You suggested that we can indeed give the template to the managed care plans. The clean copy would be great. That was my question. Thank you. And my assumption is that DHCS knows that we're going to create this template. I'm asking because Alameda Alliance is our managed care plan, and boy, are they on us. They send me an email just about every other week. Where's the MOU? Where's the MOU? And we met with them once, and we did what was suggested, kind of like the introduction. I was very frank. We saw your MOU. We won't sign that. There's things that we need to discuss. Let's back up a little bit and talk about the program. And they seemed open to that, but they still are very, very persistent. Where is it? Where is it? Where is it? So I tried not to kind of reveal the hand too much. I said that CWDA is looking at it. We want the state to have a MOU that's pretty consistent across the state, and we'd like to have time to come back to that. And I guess what I'm really asking, Diane, I'm blabbing on, is does DHCS know that we have this template so that when the managed care plans are talking to them, they won't have an issue around that?
Yep, we have been very upfront and honest with DHCS. Both on the child welfare template and the IHSS template. We have said, we've shared this with them. We have shared why we're doing it. We shared it because we wanted to get their reaction. We wanted to know, is there anything that's like off limits? And they didn't have really anything they gave us a little bit of guidance, but otherwise, they were like pretty much okay. I can't say DHCS has officially signed off on the template, because they don't really have the authority to say that, but they have said it's in line with what they would hope to see, which is that they've just put out their own baseline, but what you all do locally, what managed care plans and counties do, is really up for that discussion together, and it is a baseline to build from. Just also know, managed care plans are compliance oriented, right? And some are more so than others. You're going to have your partnership health plans that are we want to create relationships. We see this as an opportunity to really work upstream, be supporting the needs of those that are going to be served. And then there's going to be those plans that are like, you know what, this is a piece of paper, their contracts, people are going to sign it, and they're just going to want to have it implemented. So, just know that there's that balance. I want to say to that, and I'll find the link and put it in the chat again. We've been tracking the counties that have put in their status of their discussions with your managed care plans and kind of what's come out of that. I don't know if Santa Clara is on the line, but clearly you're having some challenges from what I've seen in your working with your county plan. So we're definitely tracking. There's definitely a few counties though that are saying we're just meeting, we're doing relationship building. And so that's very good to see and hear.
Thank you. I appreciate the template. We looked at it and had our county council look at it, and she was like, no, for what was shared initially from the managed care plan. She's like, we wouldn't agree to this, we wouldn't agree to that. It's just what we got from Alameda Alliance was you guys are going to do you, and it caused us to pause. So this is very helpful. Thank you for that.
And, DHCS did not run this by county councils. So as you all are working with your county councils on this, and if issues do come up, could you let us know? We just may need to flag something for DHCS, so it'll be helpful if there's something that no one had seen before and it's going to be an issue. All right, Tracy.
Thanks, Diana. First, I want to start by thanking you and your team and all of the county reps who worked on this. This is very, very helpful to have this template available. I want to talk through a little bit data. So in Contra Costa County, we are so fortunate that our county health plan is our Medi-Cal provider. We have a really strong relationship with them. We have worked through data issues with them in the past and have received a very clear directive from county council that not only must consent be given on an individual basis, but it must, in order to share data, it is time limited. So it has to be yearly, which, and that again is just our county council's interpretation. That creates an extraordinary burden on an IHSS program to try to track that yearly consent. So you mentioned that you've had discussions with DHCS about data that they would be providing. And I wonder if you can expand on that a little bit.
So Baljeet, I'll welcome you to add to this, but we know that the plans are getting some data. We are still chasing what specifically that data is, other than that it's the A codes of who is receiving IHSS. The plans are under other obligations. They are required to do risk assessments for their clients to identify populations of focus to serve in a coordinated way. And so there's like additional things outside of the MOU that they're getting, and that's why they're getting this information. So it's not just for the IHSS MOU, just to be clear. We know that Leora at DSS, the State Department Director for Adults, is very concerned about any other information and data sharing due to data breaches. So, I mean, that's about what all we know and can answer on the data piece. And we are talking regularly with DSS staff and asking them these questions. On the consent, yes, that would be a huge workload issue for you all. I am also very concerned if that would be what would be required. I know the managed care plan side, they obtain consents, but that doesn't mean that they can obtain a consent for you to share information on your IHSS program. So let us take that back, because I do think that that could be that could be definitely problematic if that's what's going to need to happen in order for you all to work with your managed care plan.
Thank you.
Diana.
Hey, good morning. I think conceptually, it all sounds good, right? Better healthcare coordinated care for our, the community we serve, but, implementing it, there's always, the devil is always in the detail. Aside from the fact that we don't have the manpower, we're already so behind, and, all the budget cuts at the state level really make it difficult to do this. And then, when you share that, there really is nothing in the end for our clients, because it's not like they're going to get priority unless they meet any other priority criteria that that is established. It's not like they go, if we contact them to provide care or whatever the service is needed, they don't get priority. So we're having to do all this, but yet it seems like we're not really benefiting. Our customers or clients are really not benefiting. And so I know, at least locally, that there are a lot of for-profit and nonprofit agencies that have already been contracted to provide some CalAIM services. They're getting paid. We're not getting paid. And so how do we tap into that money, knowing that we are, we're being cut at all different levels? And so how do we tap into some of that money to get reimbursed for the work that we're doing?
So you will definitely want to, if you haven't yet, listen to the 101 and 201 trainings, and maybe Andrea, we could drop that flyer in the chat. We just finished actually the 101 series of trainings, and so that recording will be available pretty soon. So we're into the 201s, and I would suggest doing both of those. And those talk about becoming, ECM providers and community support providers, for example. I mean, that would certainly be one way to access some funding. And, we look at, for example, in HomeSafe and the potential decrease of funding for HomeSafe. There are a lot of housing related supports and services that are going to be available, I should say, through CalAIM, and actually one that's going to be available starting January 1st, which is a 6 month of transitional rent. So but yes, like your point is well taken in terms of the staffing challenges. which is why in the MOU we put in there, to the extent your staff resources are available. That said, it is an opportunity to talk with your managed care plans about, hey, we need our healthcare providers to complete some of the forms that lead to services being the eligibility for our consumers to receive IHSS services. To the extent that there's delays from health plans to get that information from your network providers, then that's going to cause delays in those services and potentially have some risk for clients. Under CalAIM, the managed care plans are responsible for nursing home care services. So they have an incentive to not drive individuals towards higher costly care, nursing home types of situations too. So there's some incentive. The other thing is, you're not required to enter into these MOUs. They are. So in some ways, you hold a negotiation kind of advantage, if you will, on these MOUs. And so if you want to have some conversations around some of those things that will help you all locally, you have that opportunity. Baljeet, do you want to add anything?
I did participate in the first training session, not the second one, but honestly, it's still as clear as mud to me how you become an ECM provider and, bill for Medi-Cal and, checking with some of my staff. I said, well, some of these, because I'm looking to see, is there duplicate services that we're providing that others are providing and getting paid for? And, but it just seems more complex. It's not that simple. At least for me, I'm not getting it. Like, I don't even know enough to be dangerous. And so it's just frustrating. And again, I guess I'll just have to really study it.
So,
It's something you have to be familiar with and learn. It's another world. I mean, completely agree. This is complex stuff. CalAIM is not like one new initiative. It's like multiple different initiatives all wrapped into one. Like there are many components, which is why we recognize the need to do some training in this area. Don't put the pressure on yourself too much. Like just, go slow on this would be my recommendation. You have, again, like you don't have to enter into this MOU right away. It's not a requirement for you. It's a requirement on the managed care plans. Make sure you feel comfortable and understand this. The other thing is, we all have regional meetings, right? So we have long-term, our committee has regional meetings. So I would talk about this in your regions, have your staff talk about this in your regions, learn and lean from each other. We also have TA sessions. So basically it's an opportunity for you to just come and kind of ask whatever. One of my favorite teachers said the only dumb question is the one you don't ask. There is never a bad question to ask. Ask those questions. And then over time, I think it'll, we'll start to kind of figure this landscape out. We're all trying to figure it out with you.
yeah, I would just add that through the 101 and 201 that we're doing, we're learning more about what your needs are at the county level. And so, we will continue to lean more into, what does it mean to become a provider and what programs are appropriate to become an ECM provider, right? And so we are going to continue to do that. And then just want to share that CFPIC has put forward an application to become a TA marketplace vendor, which would allow us to provide even more technical assistance to each county that comes on as a recipient of TA marketplace services. And these are, free services to the counties that the state is providing to help you engage in CalAIM and understand all the components and if you want to come on as a provider, what does it mean? And so we're looking to do that. And we're going through the process of that now.
Natasha.
Hello. So I just thinking a little bit forward here. I have a little bit of concern about the policies and procedures parts of each section. So it's more of a workload question of also the oversight of who initiates those policies and procedures. Is there going to be some kind of template form in which we can follow, maybe some that aren't so county specific, but more program related, because for our smaller staff counties, policies and procedures are generally maybe one person's trying to put together procedures for a bunch of different programs. And so like currently I don't even have someone for IHSS. So I'm questioning, like, how am I going to put these policies and procedures together on top of IHSS with the managed care plan? And I know we're not at that stage yet, but I'm just trying to think forward to when that time comes, how would that look?
And I think this is where we can be a facilitative, we could play a facilitative role for you all. So first of all, the managed care plans are under this MOU requirement. They will take policies and procedures very seriously. I would not be surprised if they initiate it. I think when you talk to them in your MOU negotiation, you could suggest that they take the first stab at drafting those up. And then we can, maybe you all play a more responsive a responsive role, I should say. We could also maybe look at collecting. I mean, it's similar to the MOU. I don't think we want different policies and procedures on a county by county basis, right? Like it would be better if we just had like one set.
Yes.
So maybe that's where we can also, we'll be talking to managed care plans. Baljeet and Andrea primarily are taking the lead on having a meeting with Kaiser. We met with Partnership Health Plan. We'll meet with them again with some of these other health plans. It's going to be harder for us to do the one-offs, like for example, like Orange County. Like that might be a little bit different, difficult for us, but we can work with you all there on helping maybe create some maybe standardized sets across counties. So yeah, let us take that back, but we hear you loud and clear on this one.
All right, thank you.
Yeah. Lisa.
Hi, thanks for letting me invade your meeting. I'm the Deputy Health Officer for Marin County, and I've been kind of just supporting the MOU effort with CHUA. Quick question, you alluded to it with as you were talking about negotiations with the managed care plans. I'm just curious, one of the things in my head as we've talked about all this unfunded work is linking a financial relationship between the managed care plans and the counties. It's been conceptual in our head. And we haven't really heard of any counties that have been explicit about establishing a fiscal relationship through the MOU. So just curious if it's just in my brain, but everything that's been discussed, the body of work that's going to be needed, and honestly, to build the system of care, it's unfunded work. So curious if CWDA has been talking about that or aware of any other counties being explicit.
I'm not aware of counties being explicit about a financial relationship with the managed care plan through the MOU. Baljeet, have you heard? I have not either. I mean, I would anticipate the plans would probably push back on that, but I mean, you can certainly try. You could be our guinea pig and let us know how that goes.
Okay.
I mean, we are, of course, so through two things. The core IHSS program is underfunded, like terribly underfunded. And so, we had at CWDA budget proposal to try to at least give something to IHSS admin. We had a $15 million budget request in light of this budget situation. That is not something we're going to be able to get through, but we are still trying to push through trailer bill language to require that we do an updated methodology for funding the core IHSS work. This is above and beyond the core IHSS work, right? And so we are also thinking about, like, do we need to also specifically have an ask of DSS to fund IHSS to support the MOU work? Same with the child welfare side too. Like, these are things that are new mandates and new costs. And so we'll continue those conversations. Hopefully we'll be in a better situation in the next year or two, but that's why we put in that protective language of, we'll do this stuff to the extent we have the resources. Like, that's just the reality of the program right now.
I will add that one of the first questions that we asked IHSS around the MOU was, what do you not want to see in the MOU? And they did very clearly say anything fiscal, financially related.
The only thing, just for coming from the public health side, for your awareness, and you might have seen with the future public health funding before it was put up for on the chopping block, there was conversations around savings from that funding. to potentially apply for our mandates in population health management. So just that's like your CHIAC partners. I know you have your association, so just be aware that before the chopping block was there were conversations about identifying funding for our local health jurisdiction. I know I'm in another side of the shop from the state to fund work in that space. So I think it's great for you to go back to CDSS and DHCS to have those conversations.
And this is a good opportunity for that cross-agency work too. I mean, this is a really important point, Lisa, that county human services agencies don't bill to Medi-Cal, right? And so when we're talking about like whether or not counties can step up into some of these roles of ECM and community support providers, there is opportunities to work with public health departments, county behavioral health agencies, the agencies that have the infrastructure and know how to build to and can build to Medicaid, Medi-Cal, that there might be some opportunities for some joint work together in supporting our populations locally. So I do really encourage counties to have I'm glad that's happening. I think in some of the super agency counties where you kind of have that super agency structure, like that's kind of more on the natural, whereas if it's outside, you have to have some extended effort. And all of us are being subject to these MOUs. So public health departments, county behavioral health agencies, as well as county human services. And so we don't necessarily recommend a master MOU for all agencies. It ends up being a little complicated, we think. So we think it's better to have those individually done, but that doesn't mean you can't kind of work together so that you have some similarities in the MOUs, as well as maybe thinking about joint funding strategies.
Yeah, I think this has been an opportunity where we are as a super agency to we're holding ground with CWDA and the MOUs, but to lift up those shared parts of the MOUs. So if we're really going to build a coordinated system of care, having those, it's like you said, it's natural for us. It's not even that natural for us. We're siloed in, I'm going to overstate it. We're siloed in our own health and human services agency, but it's a forcing function for some of the cross-divisional collaboration. And I mean, it's a 10-year journey, but I think that's one of the silver linings of this.
Sherry.
Hi, Diana. I'd like to just take the opportunity to say, I'm glad to see the changes made in this template. We were looking at it, making a lot of changes on our end, and we knew some of these would be sticking points or areas of dispute in trying to develop it, right? So I'm glad to see that. And I'm also glad to hear that the discussion about the consent form. But where I believe we will have in our county, not speaking for any other counties, in our county is dispute around sin correction. Because we have an ongoing conversation with our MCPs about sin correction. When it's one or two here, that's fine. But they want to send us a list of 1,000. And we're not able to absorb that every single month for doing. So we sent them to DHCS, and now they're in conversation about DHCS on this. So when it comes to referring someone to IHSS, and it's someone, a Medi-Cal person who has, or there's a need for sin correction, I can see that coming on the IHSS side and becoming a dispute on by my IHSS team. So I say this because earlier on, Vijita, I think you were saying disputes. Couldn't think of one. I immediately thought of this one. So, and that just may be a LA County only issue, like most are.
Well, Sherry, I will admit, you have me stumped. Sin correction?
So every person receiving aid receives a client index number.
Oh, a social security number.
No, a SIN number. Client
index
CIN
number.
Yes.
Okay. I'm so sorry.
Sorry, I throw it out there because the SIN correction unit somehow ended up under me in my division.
Oh gosh. Okay.
I don't know how, but it's there.
Okay,
And so a lot of the send requests come to my team. And as we meet with our local MCPs monthly, there's always a lot of discussion about send correction. And I can see that kind of flowing into the IHSS referral, because if it's a beneficiary who has 2 or more sends, right? Our MCPs, I believe, will take this as an opportunity to push the send correction to the IHSS side, where it's not their role or responsibility, but they will have to get into it.
are any other counties having a similar experience or issue? Trying to kind of first suss out if this is, as Sherry knows, maybe just an LA issue or if it's impacting other counties? To your knowledge? I'm seeing no's, okay.
Okay, then it's
Sherry,
an
let
LA
us
County
take
only
this.
issue.
Yeah, no, well, this could be a big issue for y'all. So let us take it offline with you and maybe have a conversation, and maybe we can loop in Leora as well, or Cindy at DSS, and see how we can resolve this for you.
Diana?
Okay, I appreciate
Oh yeah,
it.
Nicole wants to jump in. Go for it.
I'll say in Alameda County, we have send issues. But usually we have a good rapport with our workforce and benefits department. We're working with the Medi-Cal eligibility worker. We have a meds liaison. So yeah, we have send clearance, but again, we put that responsibility on the other departments to make those corrections. So yeah.
Like your Medi-Cal,
Yeah, sometimes it's that, so the name may be off, the social, so yeah, you're correct. CMITs, it will be an issue where you have to do a send clearance. It should be as simple as a social worker can make a quick update and then run the send clearance and then it's good, but sometimes it's not that simple, so you may have to have a conversation with the Medi-Cal eligibility worker. In some instances, it's with Social Security, but yeah, it's just a standard thing that we encounter and we just address it and we move on.
Okay.
Got it, and thank you for sharing that.
Bringing that up.
We're used to and know how to correct SIN numbers and address them, and we have a process for SIN referrals. But it's when it's our MCPs, there are requests or a list of thousands that they want to send to us.
And it sounds like they're building up. Like, why would suddenly there be so many that they sent to you?
I don't know, but we're trying to, we sent that up to DHCS for them to address on their end. We stopped trying to address it.
Yeah.
Locally.
Okay.
But I can see it coming up, possibly, let me just say,
right.
Coming up when it comes to the IHSS referrals. In order to have a successful referral, you may have to correct the SIN number.
Yeah.
So I'll just leave it at, it may be LA. Again, we always tend to be unique. And our department, our IHSS, our Medi-Cal, CalWorks, CalFresh, we're all under the same department. So it wouldn't be a different department for us.
Right. Well, if we need to be part of the discussion, and we can also bring in our Medi-Cal folks, staff at the CWDA, and need to have a conversation around how we can make that process a bit more easier on you all. We're happy to do that. So if you're not getting the response from DHCS, so Sherry, just let us know where those conversations are, and if we need to lean in on that, we will.
Will do. Thank you so much.
Any other questions on the MOU itself and the changes that we've given you all? I don't see anything. So we have some next steps I wanted to go through. So we're going to assist counties in reaching out to Kaiser. We ourselves, we're trying to have a meeting with Kaiser, so we kind of are in the same boat with you. We're trying to have a pre-meet with them as well. And so we'll be doing that outreach, and we'll circle with the Kaiser counties. We're going to send up a cleaned up version of the template without our comments on the sidelines. we'll keep asking questions around what data and why is getting shared with managed care plans. We will actually, I need to put in the chat the link to the Google form. So that's where we want to hear from you, certainly around your discussions with the managed care plans. And then as we start to get into the discussions on policies and procedures, we will plan to try to assist you all and have some facilitative role around that. So it's a statewide process of establishing those. You have the 101 training link now. We have a meeting already scheduled, just as a reminder, with a partnership health plan for June 21st, I believe, at 9 o'clock. We sent that email out, much more respectable time than 8 a.m. today. So hopefully we'll be ready to go on that one. And we are going to try to help get some other meetings scheduled between counties and some managed care plans. So we'll do that. Anything else as far as next steps that you would like us to pursue for you all? No. Okay, Baljeet, anything else?
Not that I can think of, just like Diana said, if issues do come up, you can definitely email me and Diana, and I'll put my email in the chat again. But I am trying to really stay on top of all the nuanced things that are happening related to CalAIM at the county frontline staff level. And so if you are dealing with challenges, getting members referred to ECM or CS, and some of the work that you're doing there with the managed care plans, let us know, and we can definitely work with you to kind of resolve any issues that are coming up.
And then, one last thing is, do reach out to your APS if your APS colleagues are, in a different house. Like, do loop them in on this. Again, we do see that there are some opportunities there for that cross program work here. So not making it only about the IHSS would be, I think, the ideal goal here. So yes, okay. So you have Baljeet's email. I'll throw mine into the chat just in case. And I think with that, we're done. We will have a recording of this. So if you came late, you can listen to the first part. We will be getting, I see a couple county directors, so thank you for joining too. We're going to get this information out to the county directors too. We'll get a link of this recording. We'll get the template. Information about the partnership health plan meeting, which I haven't sent to them. So all of that, I'd like to consolidate the emails to the director since they get so many emails as well. So with that, happy Friday, happy 3-day weekending. Appreciate you all, and we'll be seeing a lot of you soon. So thanks so much. Have a great day.
Thank you.